Hello, my name is Jay Fonseca, and I'm happy to welcome you to class today. I'm one of the nurses in medical imaging, and I work on the PIC team. I first want to assure you that today will be loaded with hands-on stations and multiple different machines, and we won't be droning on about anything boring like the physics of sound and what is happening that gives you the picture you see on an ultrasound screen. No, there won't be any of that. You're here because you're tired of being blind, literally and figuratively. You're ready to wake up. You know there's a better way to start IVs. You can feel it. You ache to know what the other way is. You know there's a way to see. And that's why you're here. We're not going to waste your time, though. This class and the clinical rotation you'll sign up for afterwards are designed with intention to get you to a point of working competence as fast as possible. Give this video 20 minutes and a couple hours of practice afterwards, and we'll set you up for success. More importantly, we'll set your patients up for less sticks, less pain, and better health outcomes. But first things first, what to expect when you walk out of here? Well, it's simple. You're going to sign up for a clinical rotation over in the CT department, medical imaging here at Eastern Maine. We have a ton of patients that we see every day who are just here for outpatient CTs. They tend to be healthy. They're euvolemic. They're not your hypovolemic septic patient that people are generally screaming out for an ultrasound guided IV from. So come on over to our department. We'll get you a ton of practice. There's lots of times to sign up for, so be sure to do that before you leave. So let's begin. You are here to learn how to get those IVs in one stick on those very difficult patients, who is probably not this guy, but this isn't who we're talking about. In fact, we are specifically not talking about this guy. Ultrasound is a tool, and like any tool, it has its specific use. Ultrasound would probably make this IV more difficult, and we are not in the business of making nurses' lives more difficult. But this, yes, this is why we have ultrasound. And this, definitely this. We're going to give you the skills today where you will see this patient and actually feel a little bit of relief knowing how easy it's going to be. This guy is probably easier than the skinny guy we just showed you. But first, we need to get into the machines that we'll be using. Let's talk just a little bit about how they work and what are available to you here at the hospital. So, depending on which department you're in, there are a couple options you're going to have. It won't be long, though, that once you know the basics, you'll be able to jump on pretty much any ultrasound machine that's available to you and make it work. Now, here are the big machines we have. Most of you have seen the Sonosite on the left. That's the M Turbo, and it's sort of the workhorse of vascular access here at the hospital. Newly purchased in the ER is the Ultrasound on the right. If there is any ER nurse here, I will tell you that it's worth your time to sit down and go through the tutorial on this machine, really learn it. We will try to get this machine here for practice afterwards, or at least after this lecture, and hopefully we can give you a good foundation with it. Regardless of the machine, you're going to use the same type of probe. And that's called a linear probe. The one for the Sonosite's on the left, and the Ultrasound's linear probe is on the right. Both of these are high frequency probes, but both are capable of doing some lower frequency exams as well. What I want you to know about this is in regard to you'll be using the highest frequencies possible. This afternoon, take a moment to learn on your machine how you control the frequency. In brief, the higher the frequency, the better the resolution at the surface of the skin. The lower the frequency, the better penetration you get deeper into the tissues, but at the cost of resolution. Now, that's generally fine if you're looking at a deep structure. You won't need a super fine resolution to appreciate something that's, 10 or 12 centimeters down. But working in the topmost centimeters of the skin surface and following the tip of a needle at half a millimeter wide requires the most resolution that you can squeeze out of the machine. All that said, what I want you to remember is that on every ultrasound in this hospital, there's a way to change the frequency and therefore resolution of the ultrasound picture. Make sure you don't walk out of here without knowing how to do just that. So let's talk about the setup It's not much more complicated than a regular peripheral IV, but you do need 4 or 5 more things. Here's my setup when I walk into a room. The usual IV stuff is on the right, with the exception that the needle in this picture is a long 20. The other items I've added are the non-sterile jelly that you'll need to scout the veins. There's a coffee stirrer that you can use sometimes to mark the skin. I always grab a stack of 2x2s. This is to clean off the gel and the blood after I've gotten the IV so I can put the Tegaderm on top. And, the KY gel, this is the sterile gel that you're going to add that you'll actually put the needle through. And the final thing is the large Tegaderm that you use as a sterile cover over your ultrasound probe when you do the stick itself. Let's take a look at these IV catheters. Here are the different sizes this hospital carries, and for the most part, if you're doing an ultrasound IV, you'll want the longer 18 or 20 that I've shown you here on top. In the end, you want 2/3 of that catheter inside the vessel, which is why the site you choose can be no deeper than 1 centimeter. Any deeper than that, and you won't be able to get the catheter into the vessel without risk of displacing the catheter. We'll come back to vessel depth in a bit, but first I wanted to show you why we also say our minimum vessel diameter is 3 millimeters. Now, if you look closely, you can see just how long the bevel of the needle is before the catheter starts. It's right around 3 millimeters as well. This means that if you pierce the vessel with the needle, you're gonna get a blood return and hit the back wall of the vessel, all before the catheter has even entered the inside lumen. This is exactly why in an ultrasound, you shouldn't rely on the flash chamber to know when you're in the vein. Remember that flash chambers are built for blind sticks, which you're not doing in this case. So keep these two measurements in mind, and you should be fine as far as length of catheter and vessel goes. Make sure the top of the target vessel is no deeper than 1 centimeter, and the diameter of the target vessel is at least 3 millimeters. Now, we're not saying that you couldn't go outside of those parameters without still getting access. I have no doubt you will all become talented enough to do that soon, but each step we stray from the standard increases the likelihood of an infiltration. The holes of the Swiss cheese line up too frequently when we disregard these basic measurements. I wanted to break in real quick and teach you what seems like a simple skill, but it's applying a Tegaderm to the ultrasound probe. Use a big Tegaderm if you can, one of the ones, the old central line ones that we use, okay? It's a little bit easier, and you'll see why. Once you have the Tegaderm, take your probe, and there's going to be a little bit of gel left on the probe just from when you're scanning the patient and looking for a vein. Don't bother to wipe that off, just leave what's there. It's the perfect amount. Take the probe, take your Tegaderm, and you're going to lay the Tegaderm on 1/2 of the probe, just like that. Hold right here, and you're just going to stretch it right over, slap it down on the other side, okay? If you do it right, you've pulled the paper down on either side so that won't be in your way. You won't even have to rip the paper off, but you could if you wanted to. And then, I don't know if you can see that well or not, but there's no air bubbles. That's what you want to double check, and it's going to be on there solid. If you use the little Tegaderm, it's hard to get that over to the point where the gel is well underneath. If the gel is coming all the way down here, it won't stick to the probe. It's going to fall off while you're working. There are just so many considerations when it comes to location. In this class, we're going to focus on the upper extremity. Now, looking at this arm here, you can imagine that I've labeled the green as the ideal spots to place an IV, the yellow slightly less so, and the red even less. Now, this mostly has to do with comfort for the patient and reducing pump alarms on the floor. Please, everyone, look down at your own hand and forearm and appreciate the thumb vein that runs on the lateral aspect of the arm next to the radius. This is the cephalic vein. You also have a basilic vein on the other side of your forearm, and each of these branch off to form the brachial veins as well. When you're first scouting for veins to cannulate, start at the forearm and look for the basilic and cephalic veins. It's hit or miss on whether or not they will be at least 3 millimeters in diameter, but they are certainly worth a look. If you can't find anything in the forearm, your next stop is the cephalic in the upper arm, followed by the basilic. Later in class, we will certainly look for everyone's brachial vein, mostly because it's a good educational vascular bundle to find. It's not really awesome for cannulating though, because there's just so much in the way. Arteries, nerves, and the bicep muscle itself really complicate that vessel. Your final vessel to consider in the upper arm is the basilic. Basilics are great beginner veins, especially if you can get someone to bring their arm straight out to the side and really lay the medial aspect of the upper arm out for you. The complicating factor, though, is any loose flesh in the upper arm. You may position that upper arm wonderfully and be able to get out of the basilic vein that's nice and large and very shallow under the skin. But as soon as they pick up that arm and the tissue shifts, the catheter, which is taped to the skin, will fall away, pulling the catheter out of the basilic vein. But knowing where the veins should be is only a start. We're using ultrasound now, so we can directly visualize them. Now here we're going to look at the brachial complex. There's a lot going on here. A lot of black circles and some other obvious structures that are more of a light gray. What we need to do is identify pulsatility. This doesn't mean that we just push on it and let go and see what collapses. Both arteries and veins will collapse under pressure. The difference, though, is that arteries will pulsate back up at you as long as you hold pressure long enough for one pulse to occur. If you look here, you will see the nurse line up what she believes is the brachial vein and push down, noting that it collapses. All that proves is there is no clot, nor is it a nerve, neither of which would obliterate like that. She pushes down and holds to watch for pulsatility. You want to push and hold and count to 3. If you just bounce on the vasculature, you may confuse an easily collapsing artery for a vein. Many of the patients we're called upon to start an ultrasound guided IV may have low blood pressure for a variety of reasons. So an easily collapsing artery isn't out of the question. And if they're bradycardic and you don't push and hold, you may bounce back up off that collapsing artery before it has a chance to pulsate at you. But we're getting ahead of ourselves. Let's talk about holding the probe. As in all things, mastery of the basics will give you the most success. To that end, where you put the machine and how you hold the probe are so important. In this photo, you can draw a straight line from the nurse to the probe to the patient's arm to the ultrasound screen. Well, maybe a slightly curved line, but everything is in a nice line as opposed to the screen being at the patient's foot or something. You really have to take the time to move items in the patient's room so you can place equipment where it optimizes your approach. Don't do this. This is awful. You wouldn't want to be turning your head to look behind you or far off to the left while you guide the needle to its target. But enough about where we place the machine. Let's talk about holding the probe. This is probably even more important. Here you can see the entire lateral aspect of the hand, from the pinky to the wrist, is on the patient. The probe is just floating on the gel on the top of the arm. When you move that probe, you want to move at the shoulder and not the wrist. Moving the wrist will actually apply more pressure to the probe, and you could obliterate the vessels. A good way to practice that, and one of the first things you should do at the next station, is identify a partner's radial artery. Both sides of the artery you will find a vein. Now notice just how little pressure it takes to obliterate those two veins. Also, if you've ever wondered how an RT managed to get a venous sample on an ABG, well, you can see how here. For some bonus points, try to find the radial nerve while you're doing this as well. While we're talking about holding the probe, I would be remiss not to mention the marker on those probes. Take a moment to identify how you orient the probe. The probe marker should go to your left. This will line everything up anatomically on the screen. You can either do this by knowing your equipment and knowing what the probe marker looks like, or by physically touching one side of the probe and looking for that movement on the ultrasound screen. Once you've found a suitable vein that's less than a centimeter deep and at least 3 millimeters in diameter, it's time to scout the waterways. You want to go up and down a few inches in either direction from where you think you're going to cannulate, so you can appreciate if that vein bifurcates, if any valves appear, if it's clotted anywhere, or if the vein takes a sudden dive or turn. If you find a clot, obviously that vein is out for consideration. Nothing else, though, is a deal breaker. You just need to be aware that it's there so you're not surprised as you're trying to advance the catheter. Now, take a close look at this video. It's important to follow the vein in the direction that it travels. You don't just go up and down the arm in a straight line, you have to actually follow the vein. You can see that the vein on the ultrasound screen travels across from left to right because the nurse isn't following it. Here the nurse turns the probe perpendicular to the vein path and follows it exactly, keeping the vein in the center of the screen. It's important because the center of the screen is where your needle is, and well, you need to keep everything lined up. Now we've saved the best for last. If you remember anything, I want you to remember these next 3 slides. Step 1 is just to get the needle under the skin. Once you know where you're going, it's even okay if you have to lift the probe up off the skin, but using a little traction, pop that needle under in a nice shallow angle as you can manage, much like planting a TB test. Step 1 is just getting that needle under the skin. The next step is to get the IV catheter under the skin, and really that's the first step. Once you know where you're going, you just need to get this under the skin. I use my middle or ring finger to hold a little tension. Once I know exactly where I'm going and when I'm lined up, it's just as shallow as I can make it, 1, 2, 3, under the skin. And then keep in mind, like, I'm already a 1/4 centimeter down, even though I tried to go as shallow as possible. So keep that in mind, knowing where your vessel is. You don't want to accidentally end up all the way through the vessel. But step 1 is just get it under the skin. Your immediate concern once the needle is in the skin is to find the tip. You shouldn't make any further movements until you can find it. Slide the probe back and forth until you see it, and don't be surprised if it's as deep as a 1/2 centimeter when you first start out. Even when you get good at this, it will still appear a 1/4 centimeter under the skin. But now that the needle is under the skin and you have found the tip, it's time to sequentially advance to the vessel. Tilt the needle to no more than 45 degrees and slide the probe away from you by a 1/2 to 1 millimeter. Take a moment to appreciate just how short a distance that is. Do you want to slide the probe until the needle tip vanishes? Yes. Slide just forward enough until it vanishes and then freeze and stop everything. Now you advance the needle tip until it just barely comes into view on the screen. Stop all movement. Now move the probe up until the tip disappears. This keeps you ahead of the needle at all times so that you're not surprised and accidentally hitting a structure deeper than you think you are. Keep advancing into the vessel and recall that the bevel catheter interface can sometimes pull on the intima of the vessel for quite a distance. To increase your chances of success, you will want to sequentially advance the needle into the center of the vessel while simultaneously reducing the angle of your needle and advancing the catheter in as deep as you possibly can. Once you can't go any further without puncturing the posterior wall of the vessel, it's time to put down your probe and, using your non-dominant hand, slide the catheter off of the needle. Let's watch that. Alright, so once I'm under the skin, the next step is to find the tip. There I am, a 1/4 centimeter down. Now I'm going to make my angle steeper, and I'm going to advance my needle just until it comes into view. There it is at 1/2 centimeter. I'm going to freeze everything, forward just a millimeter. Then needle, then probe, needle, then probe, needle, then probe, all the way, very sequentially to the vessel. Once I'm in the vessel, I'm going to make my angle a little bit more shallow, and I'm going to keep following this in as deep as I possibly can. Probe, needle, and I'm doing this probe, needle, so that the bevel and the catheter interface don't grab the superficial most layer of the vessel and drag it in, making me miss my attempt. Once I can't go any further because I'm about to puncture through the posterior wall, I'll put my probe down and I'll advance with that same non-dominant hand and advance my catheter. 2 quick points before we finish up. First one's on documentation. There's really 2 things that you're going to want to add to how you would normally document a peripheral IV. The first being the length. Make sure you write 1.88 if that's the catheter you used. Also, under insertion aids, click ultrasound guided. This helps us run reports after the fact, see what our hospital wide success rate is. And we just learn a lot more when we can gather that data. So please don't overlook checking that you actually, took credit for an ultrasound guided IV. Along with documentation, we'd be remiss not to touch on vasopressor therapy. At EMMC, we have very specific requirements regarding which IVs you can infuse pressors through and what kind of veins those IVs can be in. In brief, you can initiate a pressor in any IV you feel is safe to do so if the situation is emergent, but you have to move to an ultrasound guided IV quickly. Make sure that if the order is for Levophed or whatever vasopressor you're hanging, specifically have it state that it's to be infused via PIV. Then get your ultrasound guided IV or verify the IV you have meets the criteria. That criteria is intentionally tough. The vein has to be 4 millimeters in diameter, and the catheter must take up less than 40% of the space inside that vein. Then, as long as the patient only needs one pressor and it's limited to less than 24 hours, that ultrasound guided IV is fine. If we can't meet all those criteria, then it forces the team to insert a central line. All right, now that's a lot to take in. Are there any questions? Next, we're going to break into groups and practice all of this. Remember, the 3 most important things are to get that needle under the skin, find the tip, and then stay ahead of the tip. But before we get to that, you still need to know the machine, know the name of the probe you're using, and recall that you need a high frequency to make this easy on you. Scout the arm and find a vein but differentiate it from an artery by pressing and holding while counting to 3. Today, we're focusing on the hand-eye coordination of lining up the probe to the vein, to the needle, and using just the right amount of pressure so we don't obliterate any structures. Then it's practice, practice, practice. Once you come to the department for some hands-on with actual patients, we'll integrate the setup, the prepping of the skin, and the other minutiae that come with this technique. There is still a lot to do, but for today and right now, your goal is to learn the machine and then practice the final 3 steps. Under the skin, find the tip, stay ahead of the tip. Thanks so much.